Usually, when we think about a mechanical pump breaking down, we expect a certain level of predictability, like a pipe springs a leak or a gear starts grinding.
Right, you find the broken part and you replace it. It's visible.
Exactly, it's mostly straightforward. But stepping into the world of the human heart means throwing that simple mechanical model completely out the window.
Oh, absolutely. We're looking at a diagnostic landscape that is incredibly complex. You've got structural flaws, electrical glitches, outside invaders, and they're all interacting in this dynamic, interconnected system.
And when that system starts to fail, the shock waves are felt throughout your entire body. So today, our mission is to decode those complexities. We are going straight into the architecture of the heart, the plumbing, the electrical wiring, to understand exactly what happens to you, to the human body, when this vital pump fails.
We're going to explore how that failure leads to clinical deterioration and ultimately look at the intense reality of resuscitation.
And to guide us, we are pulling from a really detailed stack of sources today. We've got clinical presentation slides on cardiovascular changes, national safety standards on recognizing acute deterioration, and a highly specific real-world case scenario to really anchor these concepts.
Right, because our goal here is to empower you with a thorough understanding of these major cardiac disorders, and more importantly, to give you the clinical intuition to spot a deteriorating patient before a catastrophic event happens.
Yeah, moving from the microscopic level of cardiac tissues straight up to the macro level of life-saving interventions. So to understand how a patient deteriorates, we first have to understand the mechanical breakdown of the heart itself. Let's start with the muscle. Cardiomyopathy.
Right, so cardiomyopathy translates literally to disease of the heart muscle. And it broadly results in impaired cardiac output, which, can lead to heart failure or even sudden death.
But the way the muscle fails comes in a few distinct forms, doesn't it?
It does. The most common one is dilated cardiomyopathy.
I always tend to picture dilated cardiomyopathy like an overstretched rubber band. Like if you pull a rubber band too far too many times, it eventually just loses its snap. It gets loose and baggy.
That's a perfect visual, honestly, because all four chambers of the heart become enlarged and stretched out. And because those muscle walls are so weakened, the heart just cannot squeeze properly during systole.
Which is the active contraction phase, right?
Exactly. So the volume of blood being ejected drops significantly, which means a really large volume of blood is just left sitting in the ventricles.
And blood isn't really supposed to be stationary. When it sits, it clots.
It does. That sluggish flow creates a really high risk of blood clots. And furthermore, that stretched out balloon shape actually alters the geometry of the heart valves themselves.
Oh, so they don't fit together right anymore.
Right, they can't close properly, leading to regurgitation where blood leaks backward. It's actually the most common cause of heart failure in young people and carries a severe risk of fatal ventricular arrhythmias.
Wow. And then we have the exact opposite problem, hypertrophic cardiomyopathy. If dilated is the loose rubber band, hypertrophic feels more like a bodybuilder whose muscles get so massive on the inside of a room that there's simply no space left for anyone to actually enter the room.
Yeah, that's a great way to think about it. And this one is primarily a genetic autosomal dominant condition.
Meaning if you inherit just one copy of the mutated gene from a parent, you have a high chance of developing it.
Yes, just a single copy is enough. The heart muscle asymmetrically increases in size and mass. It happens particularly along the septum, that's the central wall, dividing the left and right sides of the heart.
Okay.
The muscle gets incredibly thick, but the actual cavities, the ventricles where the blood is supposed to gather, they become much, much smaller.
So the heart is heavily muscled, it's working overtime, but it's actually pumping less blood.
Exactly. And it takes significantly longer for those thick ventricles to relax. That makes it incredibly difficult for them to fill with blood during the resting phase. And to make matters worse, the muscle cells themselves are disorganized.
What do you mean by disorganized?
Well, instead of lining up neatly to pull together, they grow oblique and perpendicular to each other. It severely decreases how effective the contraction is.
The sources mention this comes with a severe risk of sudden cardiac death, which is why people with this diagnosis have to really limit their physical activity.
Yeah. Treatment focuses on preventing those forceful obstructive contractions. Clinicians might use beta blockers to slow the heart rate, or a pacemaker. There is even a procedure where they inject alcohol directly into a branch of the artery, feeding that overgrown tissue.
Wait, really? Just straight alcohol?
Yeah, it causes a localized, controlled death of that specific muscle, shrinking the obstruction.
That is wild. Just to round out the muscle failures, the sources also highlight restrictive cardiomyopathy, where the walls become incredibly stiff, often from abnormal proteins or scar tissue.
Right, which has a very poor prognosis.
Yeah. And there's arrhythmogenic right ventricular cardiomyopathy, where the muscle of the right ventricle is literally replaced by fatty scar tissue. So all of these fundamentally break the mechanical squeezing action of the pump.
They do.
But the muscle isn't the only structural failure point, is it? We also have the plumbing, the aneurysms.
Right, so an aneurysm is essentially a localized sac or a bulge forming at a weak point in an arterial wall.
I always hear it compared to a bubble on a bicycle tire, but considering the blood pressures involved, it feels more like, I don't know, a heavy-duty garden hose left out in the baking sun. The water pressure inside stretches the heated rubber thin until it balloons out, and you just know it's only a matter of time before it bursts.
That's spot on. And the location of that ballooning hose really determines the symptoms. A thoracic aortic aneurysm, so located up in the chest cavity, might cause chest pain, sure, but it also causes space-occupying symptoms you wouldn't immediately link to the heart.
Like what?
Things like a persistent cough, hoarseness, or even difficulty swallowing.
Oh, because that bulging artery is physically pressing against the vocal cords or the esophagus in the chest?
Exactly. It is entirely a space issue.
Yeah.
The chest cavity is packed really tight. Contrast that with an abdominal aortic aneurysm. These occur much lower down, typically below the renal arteries that supply the kidneys.
Right.
Only about 40% of people ever develop symptoms before a crisis. But when they do, it presents as a central abdominal pain that intensely radiates to the lower back.
The sources mentioned patients sometimes complain they can actually feel a heartbeat in their stomach. I mean, I can't imagine how terrifying that would be.
It's definitely alarming.
But the fix for this has evolved, right? They don't always have to open up the entire abdomen anymore.
No, thankfully. In many cases, they can perform an endograft repair, which is vastly less invasive. Surgeons make a small incision in the groin, navigate a catheter up through the blood vessels, and deploy a stent graft inside the weak part of the aorta.
So it's essentially creating a brand new reinforced pipe inside the failing one, taking the pressure off the weak wall.
You got it.
Okay, so we've seen how structural flaws can be genetic or caused by intense wear and tear like aneurysms, but the heart can also be destroyed from the outside. Which brings us back to that horror movie scenario I mentioned at the start, rheumatic fever and endocarditis.
Yeah, the mechanism of how a systemic infection zeroes in on the heart valves is just a masterclass in biological misdirection.
Let's really break this down. How does a basic sore throat eventually lead to the physical destruction of a heart valve?
It all comes down to an autoimmune phenomenon called molecular mimicry. So, rheumatic fever begins with an upper respiratory infection caused by group A streptococcus.
Which is just what we know as strep throat.
Exactly. The bacteria itself doesn't eat the heart, your own body does.
So it's literally friendly fire.
Total friendly fire.
No.
Your immune system detects the strep bacteria and manufactures specific antibodies to destroy it. But the problem is, the proteins on the surface of the strep bacteria look molecularly very similar to the proteins on your own heart tissue.
Oh, wow.
Specifically the endocardium and the mitral valve. So long after the sore throat is cleared up, those circulating antibodies get confused. They lock onto your own heart valves and initiate an inflammatory attack.
That's terrifying. And the statistics in the sources show this primarily affects kids and young adults like 5 to 20 years old. But this isn't a disease distributed evenly across populations, is it?
No, not at all. Rates of acute rheumatic fever are dramatically higher among Aboriginal Australians, Torres Strait Islander people, Maori, and Pacific Islander people.
And that's linked to environmental factors.
Heavily. It's linked to overcrowded living conditions and socioeconomic barriers that foster the rapid transmission of that initial strep infection. The long-term result of this autoimmune attack is rheumatic heart disease, meaning permanent scarring, thickening, and stiffening of the heart valves.
And once those valves are scarred and roughened, they become the perfect jagged breeding ground for the next issue, right? Infective endocarditis.
Exactly. Endocarditis is a direct infection of the inner lining of the heart and the valves themselves. When a valve is already damaged from rheumatic fever, that smooth surface is gone. It's so much easier for any bacteria in the bloodstream to latch onto those rough edges.
And they start to multiply and form clusters called vegetations.
Yes.
The sources mention these vegetations are made of bacteria, platelets, and fibrin. What exactly is fibrin doing in there?
Fibrin is essentially the body's natural netting. It's a protein that helps form blood clots. The bacteria hijack this netting to build a protective shield around themselves, making it incredibly difficult for the immune system or even antibiotics to reach them.
Wow. And the physical signs that this is happening are just bizarre. The sources list Osler nodules and Janeway lesions. Why on earth would an infection on a heart valve cause spots on your hands and feet?
Because the heart is violently pumping blood past these fragile vegetations. Tiny pieces of that infected bacterial netting break off and travel through the bloodstream as emboli.
Oh, I see.
Yeah, they get pumped to the furthest extremities, the microcapillaries in your fingers and toes. When they wedge in those tiny vessels, they block flow and trigger localized immune responses. That's why you see Osler nodules, which are painful, swollen bumps on the fingers or toes.
And the Janeway lesions.
Those are painless, flat, red microhemorrhages on the palms and soles.
To bring this out of the abstract, our sources actually include a case study. We have Nakao, a 17-year-old Maori boy. 3 months ago, he had a sore throat, which triggered that autoimmune molecular mimicry we just talked about.
Right. His immune system attacked his valves.
Then, 6 weeks ago, he received a traditional tattoo and a tongue piercing using sharp animal bone tools.
And that was the entry point. The piercing and tattooing introduced environmental bacteria directly into his bloodstream. Because his heart valves were already inflamed and roughened from the recent rheumatic fever, that bacteria found the perfect place to anchor.
So now he presents to the hospital with a 40°C fever, extreme fatigue, a new heart murmur, and an echocardiogram showing actual vegetations growing on his tricuspid valve.
The structural damage literally set the stage for the infectious destruction.
It's just a brutal sequence, but we've coupled the muscle, the vessels, the inner valves. There's one more structural layer, the sac holding it all together, pericarditis.
Yeah. The pericardium is a tough, double-layered, sac-like membrane surrounding the heart. When it becomes inflamed, it creates a highly distinct type of chest pain and a very specific sound.
The sources describe a creaky or scratching friction rub that you can hear with a stethoscope, mostly at the end of an exhalation. And the pain is uniquely positional, right?
Extremely positional. If the patient lies down, the pain intensifies because the inflamed layers are pressing directly against each other. But if they sit upright and lean forward, gravity pulls the heart slightly away, and the pain is relieved.
But the true clinical danger here is a complication called a pericardial effusion, right?
Yes. This is when the inflammation causes a rapid buildup of fluid between the two layers of that sac.
I sort of picture this like wearing a suit of rigid armor that suddenly starts filling with water. Like the heart wants to expand to pull in blood during its resting phase, but it physically hits a wall of fluid.
When it hits that wall, we enter a state called cardiac tamponade. The fluid compresses the heart so severely that it chokes off its function.
Wow.
The physics are simple. If the heart cannot expand to fill with blood due to external pressure, it cannot pump blood out. Cardiac output just plummets rapidly.
Okay, so whether it's an overstretched muscle, a bacterial cluster shredding a valve, or an armor of fluid crushing the heart from the outside, when the heart begins to fail, it sets off a systemic chain reaction. If you're listening to this and wondering how doctors don't miss these subtle signs when they might be managing 20 other patients on a ward, this is where standardized observation comes in. How do clinicians spot this deterioration before the patient crashes?
Well, they rely on the National Consensus Statement on recognizing acute deterioration. The foundational concept here is that deterioration is a process, not a singular sudden event.
Right.
It includes physiological vital sign changes, but crucially, it also includes psychological and cognitive changes that can unfold over hours or days. A sudden, unexplained onset of delirium or agitation is a massive red flag that the brain isn't getting enough oxygenated blood.
So it's not always the dramatic movie scene of someone clutching their chest. It can be super subtle. To catch it, hospitals use track and trigger graphical observation charts.
Exactly. Instead of just writing down numbers on a clipboard, clinicians plot the patient's vital signs on a chart broken into color-coded zones. If a patient's heart rate or respiratory rate slowly drifts into an orange or red zone, it visually triggers a mandatory protocol-driven response.
And that response is often a MET call, a medical emergency team. The triggers for this are pretty stark.
Very stark. The criteria are designed to catch extreme physiological stress. A MET call is triggered if breathing drops below 8 breaths a minute or skyrockets above 25.
Okay.
Or if the pulse drops below 40 or persistently stays above 110, if the systolic blood pressure drops below 90 millimeters of mercury, or if there is any sudden, unexplained drop in their level of consciousness.
I look at all this data, the color-coded charts, the strict numerical criteria, and I wonder, Isn't there a danger of clinicians just treating the monitor instead of looking at the actual human being in the bed?
That is a very well-documented risk in modern medicine, and it is precisely why the most brilliant and vital part of these guidelines is what they call the worried criterion.
Oh, what does that mean in practice?
It means that staff, patients, or even the patient's family can escalate care and trigger an emergency medical team simply because they are worried or concerned about an acute change in the patient's condition.
Even if the numbers are fine.
Even if the vital sign numbers haven't perfectly crossed into the red trigger zones yet. It intentionally validates human intuition alongside raw data.
That's amazing. It respects that a seasoned nurse or an observant family member might sense a shift in the patient's skin color, their energy, or their behavior long before the blood pressure cuff sounds an alarm.
Exactly.
But what happens when the warning signs are missed or the deterioration simply happens too fast? The heart stops. We enter the ultimate emergency. Resuscitation. What is the actual mechanical protocol for stepping in?
Basic life support follows the DRS ABCD algorithm. Danger, response, send for help, airway, breathing, CPR, and defibrillation. The physical mechanics of CPR are absolutely critical for maintaining any semblance of organ perfusion.
Right.
You compress the chest at a ratio of 30 compressions to 2 breaths, operating at a fast pace of 100 to 120 beats per minute. You must compress down 1/3 the depth of the chest and crucially allow for complete recoil.
Meaning you have to let the chest come all the way back up.
Exactly. If you don't let the chest fully rise back up, the heart has no negative pressure to pull new blood in.
Does that mechanical protocol apply to everyone? Like, what if the patient crashing is an infant?
Well, anatomy dictates technique. For an adult, you use the heels of both hands and aggressively tilt the head back to open the airway. But an infant under 1 year old has a vastly different structure.
Because they're so small.
Yeah, and their trachea is soft and highly pliable. If you tilt an infant's head far back like an adult's, you will actually kink and block their airway.
Oh, wow, I didn't know that.
Yeah, you must keep an infant's head in a neutral position. And for compressions, you use a much smaller 2-finger or 2-thumb technique.
Got it. So chest compressions manually force blood through the body, but to restart the electrical system, you need advanced life support, the defibrillator. But you can't just shock everyone who has collapsed, right? I feel like television has deeply confused us on this point.
Oh, television constantly shows doctors shocking a flat line, which is entirely medically inaccurate. There are shockable rhythms and non-shockable rhythms.
Okay.
A defibrillator is designed to be used on a shockable rhythm, like ventricular fibrillation, where the heart's electrical signals are chaotic, causing the muscle to just quiver uselessly, or pulseless ventricular tachycardia.
So the shock isn't a jump start.
No, it's a massive reset button. It stuns all the heart cells at once, hoping the heart's natural underlying pacemaker can reestablish a normal rhythm.
Wait, so if I'm looking at the monitor and it shows a systole, a complete flat line, I can't shock that.
Yep.
What about pulseless electrical activity? Like, the monitor is beeping like there's a heartbeat, but if you check the patient's wrist, there's no pulse at all. The electricity is firing, but the pump is totally broken.
Both a systole and pulseless electrical activity are non-shockable. You cannot shock a heart that has zero electrical activity, and shocking an organized electrical rhythm that lacks a mechanical pulse won't fix the underlying mechanical failure.
So what do you do?
In those cases, you must focus relentlessly on CPR to circulate blood, administer medications like adrenaline to stimulate the cardiovascular system, and critically, figure out why the heart stopped in the first place.
This is where the critical care team has to act like detectives in the middle of a crisis. The sources call these reversible causes the 4 H's and 4 T's. We need to spend some time here because this really connects everything we've talked about. Let's look at the H's first.
Hypovolemia is the first H. This means a severe loss of blood or bodily fluid. Simply put, the pump has stopped because there is no fluid left in the pipes to pump.
Makes sense.
Hypoxia is the second, a profound lack of oxygen reaching the tissues, causing the heart muscle cells to suffocate and cease firing.
Then there is the hydrogen ion, which is a complicated way of saying severe acidosis. What does acidic blood actually do to the heart?
When a patient's blood pH drops and becomes too acidic, the proteins within the heart cells begin to alter their shape, and the cellular enzymes stop functioning. The electrical gradients required for the heart muscle to contract are completely destroyed.
Oh, so the heart literally cannot operate in a highly acidic environment.
Exactly. The final 2 H's are hyperkalemia, abnormally low or high potassium levels, and hypothermia, where profound cold slows the metabolic process to a halt.
And then we have the 4 T's. Toxins, like a massive drug overdose. Thrombosis, which we discussed earlier with dilated cardiomyopathy, a massive blood clot forming in the heart or breaking off into the lungs, physically blocking blood flow.
Right.
Then tension pneumothorax. Can you explain the mechanics of how a lung issue stops the heart?
Sure. A tension pneumothorax occurs when a lung is punctured or damaged, acting like a one-way valve. Air leaks out of the lung and into the chest cavity with every breath, but it can't escape.
So the pressure just builds and builds.
Exactly. The pressure inside the chest cavity rapidly builds, eventually physically shoving the heart and the major blood vessels to the opposite side of the chest. The massive veins bringing blood back to the heart get kinked and crushed by this pressure. Blood can't get in, so the heart stops pumping blood out.
And the final T is tamponade. This is exactly what we covered with pericarditis. The fluid builds up in that pericardial sac, crushes the heart from the outside, the patient deteriorates, triggers the MET call, and if that fluid isn't immediately drained by a needle, the patient codes and requires resuscitation.
Yes, the micro-level structural failure directly causes the macro-level systemic collapse. It is an unbroken chain of causality. If you don't drain the fluid causing the tamponade, no amount of chest compressions or adrenaline will permanently restart that heart.
Being well-informed in this space really means understanding the why behind the what. We started today looking at the heart not as a simple machine, but as a dynamic landscape. We've traced the journey from the cellular architecture of an overstretched, dilated heart to the molecular mimicry of Nuckhaus rheumatic fever, right down to the scratching friction rub of pericarditis.
And we followed that breakdown all the way to the bedside, looking at how track and trigger charts, clinical MET calls, and the swift mechanics of CPR and defibrillation attempt to pull a patient back from the brink of systemic collapse.
Knowing why an infant's head must stay neutral to protect their soft airway, why you cannot shock a flatline, and how a simple sore throat can ultimately destroy a heart valve, it all comes down to seeing the interconnected system.
It definitely requires looking past isolated symptoms to understand the biological mechanisms driving them.
As modern hospitals increasingly rely on automated algorithms, wearable continuous monitoring, and predictive AI to catch clinical deterioration, I want to leave you with a thought to mull over. Will that deeply human instinct, that crucial, unquantifiable, worried or concerned criterion on the medical charts eventually become obsolete? Or is the human element, that gut feeling that something is profoundly wrong before the numbers ever show it, the one variable that technology can never truly replace?